Hello, everyone, and welcome to this webinar on carcinoid heart disease. My name is Alan Lewis, and I am one of the cardiologists that specializes in carcinoid heart disease. And I'm joined by my esteemed colleagues, Dr. Thor Halfdanarson, who's a professor of oncology and president emeritus of the North American Neuroendocrine Tumor Society, and my esteemed surgical colleague, Dr. Juan Crestanello, who's our director of cardiac surgery and one of our experts at operating on patients with carcinoid heart disease. I'm going to start by handing over to Dr. Halfdanarson to get us underway here.
Thank you very much. It's really a pleasure to be a part of this webinar. So here are my disclosures. And what I thought I would do for the next 10 minutes is to explain neuroendocrine tumors just briefly to you. So neuroendocrine tumors are cancers, essentially, that can arise almost anywhere in the human body. And they can happen in the small bowel, which is probably the most common place, lungs, pancreas, and other parts of the body. Extremely heterogeneous group of cancers. So I sometimes say that no two neuroendocrine tumor patients are the same. So you can have patients with seemingly similar neuroendocrine tumors starting in the small bowel, but with totally different presentation, different symptoms, and so on. And these tumors can at times produce multiple different hormones that can cause multiple different symptoms and even some organ damage, and we'll talk about that here in a little bit. And one of the hormones that's commonly produced by this tumor is a hormone called serotonin, and these tumors can produce sometimes very, very large quantities of that. So neuroendocrine tumors are becoming more common. So these two pictures here should show you changes in the incidence of neuroendocrine tumors. So incidence is the number of new cases diagnosed over a time period, like a year. So let's say if the incidence is 10 per 100,000 per year, that essentially means then that in a town like Rochester, you would expect to see 10 cases per year. But what I wanted to bring to your attention is are these curves here. For example, the green curve, these are numbers from England reported a few years ago, and this goes back 10, 20 years, and you can see that these tumors are just becoming a lot more common. These are a little older data from the US. We see the same. So a lot of these tumors are being diagnosed incidentally. So someone goes in for a CT scan for another reason, totally unrelated. They may have slipped on the ice or had a motor vehicle accident, have a CT, and there is a neuroendocrine tumor that no one knew of. So that's called incidental diagnosis. That's a lot of these diagnoses. So next I wanted to talk to you about the carcinoid syndrome, because that really is what we are talking about here today. So I want to talk about what causes that and why this can be damaging to body parts. So let's walk through the biology of neuroendocrine tumors. So here you see a neuroendocrine tumor cell. On the surface of the tumor cell, we have these little little things called somatostatin receptors, and we'll talk about those in a little bit here in a moment. So the neuroendocrine tumor cells can produce this hormone called serotonin, and that can be measurable in blood. And if that's left unchecked and elevated, it can cause a lot of different problems, including diarrhea, tissue fibrosis or scar tissue formation in tissues, and heart valve damage, which is the topic of today's webinar. And the serotonin is not the only hormone produced by neuroendocrine tumors, but it's the hormone we're going to be talking about today. And we can sometimes treat this with medications that attach linked to the somatostatin receptors on the surface of the tumor cells and can actually reduce the production of the serotonin. We'll talk about that here in a moment. So here are a few of the symptoms of the carcinoid syndrome. So one of them is cutaneous or skin flushing. It's this sort of red, purple discoloration of the skin. This comes and goes and sometimes only lasts for a few seconds, but as the tumors grow and produce more chemicals that cause this, you get to see more of this and it stays longer. This actually, interestingly, is not caused by serotonin. It's caused by other chemicals that the tumors produce. Then we have the diarrhea. So diarrhea is very, very common. This is caused by serotonin. This is the most disabling symptom of the carcinoid syndrome. And then sometimes we have wheezing, almost like asthma, where shortness of breath and wheezing. And if you have elevated serotonin for a long time, it can, as I said before, damage normal tissue through scar formation. And how serotonin does this is not fully understood. But the problem is that once the damage has happened, it's very hard to reverse it. It's very hard to fix damaged tissue. And so the goal of our treatment, among other things, is to control this tissue damage or minimize it if we can. So how do we diagnose neuroendocrine tumors and carcinoid syndrome? It's a team effort. We need the radiology, pathology, clinical chemistry, and we actually need a lot of other different teams. So imaging is critical. So a good imaging team is, as I sometimes say, it's a team activity or a team sport if you want to use the sports analogy. So you need expert radiologists and nuclear medicine specialists, you need good equipment, and you need really good technicians, because without a good technician, we won't get good results. So that's very critical. And this is just an example of what we can see from imaging. This is called a somatostatin receptor PET study. You can see the liver here. That's this big yellow-green organ. You see the little red dots here. So, and you can see this big red thing here. It's actually your spleen. That's normal. And if we look at the CT, you see those little white or light gray spots. These are liver metastases that can be very, very hard to see. And these can produce a lot of serotonin that then can cause some tissue damage. So how do we treat patients with neuroendocrine tumors and carcinoid syndrome? There are several different ways to do this. We can treat locally, meaning that we can remove them surgically, or we can treat with medications. So the principles of NET therapy are essentially three major goals. There are more goals, but these are the major goals: to prolong life or life expectancy, and cure if we can. We cannot always do that. To treat symptoms and to improve or maintain quality of life, and then to prevent later complications, including reducing the serotonin production. But the interesting thing here is that not everyone with advanced neuroendocrine tumor needs to be treated right away. If you have symptoms such as carcinoid syndrome that causing you symptoms that are troublesome, decreasing your quality of life, yes, that should be treated. Some people need to be treated urgently, but some can wait, sometimes even for a few years. So essentially you treat when you really need to. And you have to be careful with the toxicity or side effects. All treatments have some toxicity. It can be sort of side effects as we see with medications, or it can be what we call financial toxicity. These drugs can be very costly. And oftentimes the treatment requires multiple treatment visits, so that can be very challenging as well. So the regional therapy, as we call it, this is treatment of localized neuroendocrine tumors. An example of that would be surgery for a localized tumor, which can be done sometimes with curative intent, sometimes to reduce what we call the tumor burden, and can often result in very durable palliative effects. So if you have symptoms of carcinoid syndrome, but we remove the liver metastases that are producing the serotonin, that can last for years. There are some other regional treatments than surgery. We can do what's called tumor ablation, put a small needle into the tumor and burn it or freeze it, and we can do what's called liver artery embolization or radiation treatment. And the newest embolization technique is something called histotripsy, where we use ultrasonic sound waves essentially to shake the tumors apart. So that's fairly new, and we'll have to see where that fits in. So the systemic therapy, so this is the drug therapy part. So we use a class of drug called somatostatin analogs, who have two major roles. They can stop tumor growth and reduce the production of chemicals like serotonin. And we have other treatments than somatostatin analogs that may or may not reduce the serotonin production, and we won't talk about those here. So just to go back to the neuroendocrine tumor cell, so we can see here's a neuroendocrine tumor cell. It's producing a lot of serotonin, causing some risk of tissue damage, like heart valve damage. So we have this receptor, as I told you, we can target. And if we use medications that target that receptor, then we can actually stop the production of the serotonin, which now has dropped substantially. And now there's a lot less risk of tissue damage, less diarrhea and less flushing. This typically lasts for a few years, sometimes even much longer than that, but sometimes doesn't last very long. There is another way to target this using radioactive chemicals, something called radioligand therapy or peptide receptor radionuclide therapy. So now what we do is that we target the same receptor with a small radioactive chemical that sends a lethal dose of radiation to the tumor cells but spares the surrounding normal cells, and that can really effectively control tumor growth, reduce the production of the serotonin and can really improve quality of life and often prolong life as well. So that is, in a nutshell, the treatment of neuroendocrine tumors and the background of the carcinoid syndrome. So I will hand it over to the next speaker.
Thank you very much. And so we're going to change gears a little bit here and move to the next phase, which is talking about carcinoid heart disease. And so carcinoid heart disease is the result of the circulating hormone, the serotonin that Dr. Halfdanarson just spoke with us about. And like in other tissues, it also causes fibrosis of the valvular leaflets. The predominant cause of carcinoid heart disease is not metastatic disease, but rather it is the result of fibrosis of these valve leaflets. The serotonin entering the heart affects the tricuspid valve and pulmonary valves, and it's thought that the serotonin is metabolized in the lungs, resulting in a decreased amount of serotonin to the left heart, and so a reduced incidence of mitral and aortic valve disease as compared with tricuspid and pulmonary valve disease. So what we see macroscopically is that the valve leaflets are incredibly thickened. These leaflets should be only paper thin essentially, and they should be able to flap freely in the blood flow. But you can see that these valve leaflets on the left for the tricuspid valve are almost half an inch thick. And so you can imagine that these leaflets go from paper thick to cardboard, and so that cardboard doesn't move freely in the blood flow, and so it's no longer able to coapt and close off the blood flow. And if we look at it microscopically, what we can see is that the leaflet is not damaged by this process. In fact, what happens is you get this fibrous carcinoid plaque. It's rich in collagen with a few fibroblasts, and that is added on over the top of the leaflets, be it the tricuspid, be it the pulmonary, or be it any other valvular tissue, and that really is what reduces the mobility of the leaflets here. In terms of screening for carcinoid heart disease, what we really want to do is to find the disease early and to be able to follow our patients. One of the algorithms from this international consensus statement really suggests that NT-proBNP may be a good starting point for screening of carcinoid heart disease. And the reason for this is it's widely available and easy to obtain. If the value is over 260, then these consensus statements suggest that we should look at patients further with an echocardiogram. Now, really, if you choose to go to an echocardiogram up front instead of doing an NT-proBNP, that is not unreasonable, but it may be a more expensive test up front. I think it's important to realize that if the NT-proBNP is abnormal, it doesn't necessarily mean that you have carcinoid heart disease. What it tells you is that your patients need further screening for the presence or absence of carcinoid heart disease. And if that NT-proBNP is high, we would recommend screening with echocardiography, looking for signs of carcinoid heart disease. So when we look at the tricuspid valve echocardiographically, what we can see is that you have the tricuspid valve leaflets. They become shortened, they become really, really thick, and they don't move. The other thing you notice is that there's a visible coaptation defect. These leaflets do not come together and do not seal off during systole. And so this results in a large amount of backflow or tricuspid regurgitation between the right ventricle and the right atrium, which you can see here, really marked color flow. It's really important to also assess the pulmonary valve. The pulmonary valve can be hard to see, and this is actually a nice illustration of the pulmonary valve where you can see the valve leaflet, but it is not infrequent that pulmonary valve disease and carcinoid heart disease is underdiagnosed and that patients at some institutions may have tricuspid valve replacement without recognition of the pulmonary valve disease. The color Doppler can be hard to interpret, and one of the key things in making the diagnosis of pulmonary valve disease is really to look at the Doppler signals. And what we notice is that the Doppler signal is fairly dense there. It is also important in echocardiography to look for an interatrial level shunt. So an atrial level shunt really increases the risk of left-sided heart disease. And so all patients with a suspected diagnosis of carcinoid heart disease or with a diagnosis of neuroendocrine tumor or carcinoid syndrome should have an IV line placed for at least their first echocardiogram, and they should be assessed with an agitated saline injection. And what you can see on this echocardiogram here is bubbles initially entering the right heart, but also crossing over early and filling that left heart, consistent with an atrial level shunt. So what about monitoring patients for carcinoid heart disease? And this is another diagram from that same consensus statement that we were referring to earlier. If the diagnosis of carcinoid heart disease is suspected and you do an echocardiogram, you would then reclassify your patients. Do they have mild carcinoid heart disease, or do they have moderate or severe carcinoid heart disease? In your patients with mild carcinoid heart disease, if they're asymptomatic, you would continue to follow them up with periodic echocardiography. If they have severe disease, you would consider, do they have symptoms or not, and do they warrant intervention or not? I think it's really important to recognize, unlike other valvular heart disease, carcinoid heart disease can progress incredibly rapidly. And so carcinoid heart disease can go from nothing to severe valve disease in as little as 6 to 12 months. And so our screening frequency with follow-up for carcinoid heart disease tends to be every 6 to 12 months in this patient population. So what are the surgical interventions for valvular heart disease? And really, the indications for valvular heart disease and surgery for this most frequently follow the usual American College of Cardiology and American Heart Association guidelines for valvular surgery. One of the major indications is symptomatic valvular disease with severe valve disease defined on echocardiography. With the right heart often being affected, the right ventricle may be dilated or dysfunctional, and so progressive right ventricular enlargement or progressive right ventricular dysfunction is also an indication for surgery. And one of the unusual indications for surgery in this particular patient population with severe valvular disease is Dr. Halfdanarson talked about intervention to the liver and treating metastatic disease in this patient population. And so if there is severe valvular heart disease, particularly affecting the tricuspid valve, and your patient is going to undergo liver surgery, their central venous pressure will be elevated. And so at the time of liver surgery, they would have increased bleeding. And so the hepatic surgeons will often ask us to fix the tricuspid valve prior to addressing the liver. And so that would be an unusual indication for surgery that may not be in keeping with our usual indications when we think about non-carcinoid heart disease here. In terms of predictors of survival, the major predictors of survival are age. So the older we are, the less well that we do. Another major predictor is that of NYHA class. The more symptomatic the patient, the less well that they do. And the worse the renal function or creatinine, the worse that people do. This is unlike other cancer. This is really a disease with good longevity in comparison to other tumors. And so this is a disease where treating the underlying valvular heart disease can prolong overall survival. And this is from work done here at Mayo Clinic. In terms of the choice of valve prostheses, this was also work done at Mayo Clinic, and we looked at the patients at our institution that had tissue valves as well as mechanical valves. And we found that the outcomes for both tissue and mechanical valves were comparable. We know that right-sided valves, particularly a tricuspid mechanical valve, does have a higher incidence of valve thrombosis, and that this patient population may need frequent intervention over time. And so our practice has more so moved to using tissue valves here in this patient population, particularly on the right side. It's really important to recognize that the management of carcinoid heart disease requires an experienced team of individuals with experience managing not just valvular heart disease or not just experience managing neuroendocrine tumors, but really expertise managing carcinoid heart disease. And with the patient at the center, this team involved the oncologist, the cardiologist, the cardiac surgeon, the anesthesiologist, and multiple other specialties. And really, it's important to remember that the entire team needs to be specialized in both the tumor as well as carcinoid heart disease in order to ensure optimal outcomes. So in conclusion here, carcinoid heart disease is relatively common, affecting at least 1 in 5 people with carcinoid syndrome. We know that cardiac valve replacement improves overall survival from carcinoid heart disease. Cardiac surgery should really be performed at centers of excellence with experience managing patients with carcinoid heart disease. And bioprosthetic valve replacements using tissue valves may have comparable outcomes to those with mechanical valve prostheses. And it's my pleasure now to hand over to Dr. Crestanello here to talk about surgery for this disease process.
Thank you. I'm going to talk today about surgery for carcinoid heart disease. Carcinoid heart disease occurs in 20 to 50% of the patients with carcinoid syndrome, and is characterized by fibrosis of the tricuspid and pulmonary valves, as Dr. Lewis previously described, with deposits of this fibrotic plaque on the surface of the valve. That leads to tricuspid and or pulmonary valve regurgitation or stenosis and symptoms of congestive heart failure. Our experience, we have operated in 290 patients with carcinoid heart disease who require valve replacement. This is the typical aspect of the valve. This is the tricuspid valve, which is involved in 99% of the patients, almost all of them. And we can see this whitish discoloration of the valve with thickened leaflets, as well as thickening of the subvalvular apparatus. We also see carcinoid plaques on the wall of the right atrium. Sometimes the valves are so scarred that lead to stenosis, like in this case. Tricuspid valve replacement is performed on those patients using bioprosthesis. The pulmonary valve is involved in about 84% of the patients, and here we can see the cusp of the pulmonary valve that are also thickened and with whitish discoloration because of the deposit of the carcinoid plaques. Here we can see the pulmonary valve replacement with the bioprosthesis. We normally augment the right ventricular outflow tract, the pulmonary valve annulus, and the main pulmonary artery with a pericardial patch in order to accommodate a large bioprosthesis. The left-sided heart valves are involved in 16% of the patients, and here we can see the involvement of the mitral valve and the aortic valve with the same aspects of the cusps, which are thickened and with whitish discoloration. This is the summary of our experience. The tricuspid valve is involved in 99% of the patients, pulmonary valve in 84%, left-sided heart valves in 16% of the patients, and double valves, mostly the tricuspid and the pulmonary valve, are affected in 3/4 of the patients. The ASD and PFO is identified in about 1/4 of the patients, and in those circumstances, we always close to prevent involvement of the left-sided heart valves. 84% of the patients, the valves are replaced with a biological valve, 16% with a mechanical valve, and no valve repairs. This is an ongoing process that will recur if we try to repair the valve. The recurrence of the carcinoid in the bioprosthesis is very rare. In our experience, of the 23 patients who required reoperation, only 3 patients had a recurrence of the carcinoid in the bioprosthesis. The perioperative management is very important. The carcinoid crises are very rare, but they are rare because we use long-acting somatostatin analogs that are normally we recommend to administer a week before the surgery, and we use continuous infusion of somatostatin for 48 and sometimes 72 hours after the surgery with rescue doses if necessary. The incidence of prosthetic valve thrombosis in these patients is higher, and therefore we recommend anticoagulation with Coumadin for 6 months after the surgery. The survival of these patients after surgery, the operative mortality has improved over the years, and is mostly related to the improving the surgical techniques, the perioperative management, and fundamental to the use of the somatostatin analogs to prevent carcinoid crisis during the surgery or in the perioperative period. The median survival is 3 years after the surgery, and these patients die from progression of their disease rather than from congestive heart failure. The majority of the patients after surgery are in functional class 1 or 2. The determinants of survival are tumor factors as well as cardiac factors. The tumor factors are the presence of bone metastasis and a metastatic burden in the liver that is greater than 75%. From the cardiac standpoint, patients who are in New York Association functional class 3 or 4 or who has right ventricular dysfunction had a worse survival. To conclude, carcinoid heart disease valve surgery improves early mortality as well as the symptoms of right heart failure. Late survival is limited by tumor burden or progression of the tumor disease. The carcinoid involvement of the bioprosthesis is very rare, and early operation might decrease the operative mortality and improve long-term survival. Thank you very much.
We have a couple of questions here from the audience, and the first one is for Thor. And you really brought up that the incidence of neuroendocrine tumor is increasing. And this astute audience member asks us, is that just that we're recognizing more of it, or do we think that it's actually increasing over time?
So that's a really excellent question. So I think a lot of it has to do with the increase in what we call incidental diagnoses. So these were tumors that were always there. We just didn't know about them because we were not doing scans. So some of those patients would have gone maybe for another 2 or 3 or even 10 years without knowing, and then ultimately presented with much worse disease. That said, many of us also believe that there is also some real increase, that we're seeing more neuroendocrine tumors, and we do not really understand why. The other thing I wanted to mention is a concept called prevalence. So prevalence is somewhat related to incidence. The incidence, as you may recall, is the number of new cases over, let's say, a year. The prevalence is actually the number of patients living with the disease at a given time or having had the disease in the past and undergone a surgery. So because patients with neuroendocrine tumors live for very long, much longer than many other cancers, there is going to be a lot of neuroendocrine tumor patients around. So the prevalence is actually very high. So we don't know I think it's mostly incidental diagnosis, but I think there's a real increase as well.
Okay. Do you think that there's any particular increase for that, reason for that real increase?
No. So there have been some speculation. So going back 20, 30 years ago, there was a study from Sweden looking at the sort of national hospital registries there, and they saw some suggestion of certain like occupations, people in the petroleum, chemical industry, exposed to a lot of chemicals might have had more neuroendocrine tumors than one would have expected. There was a study from Utah that looked at patients who grew up around like mining towns, and there were the speculation that like the water runoff from those might be toxic, but none of that has been proven. These are sort of like leads that I think we should follow, and we haven't really done that yet to really study what we call geographic variations. Why are people in this area maybe more likely to get the neuroendocrine tumors than people in that area? It could be as simple as the doctors in that area are just more aware and more likely to scan than the doctors in the other area, or it could be really that there's more neuroendocrine tumor there.
Excellent. The next question that we have here, I'm going to take a crack at, and then I'll hand it over to you, Dr. Crestanello. So the question is really, what transcatheter options do we have for this disease process? And the question here really is, TriClip or other transfemoral interventions an option in this patient? The problem with edge-to-edge repair for valvular heart disease, particularly the atrioventricular valves, is as I showed you on the echocardiographic pictures, your two leaflets are stuck miles apart. Edge-to-edge repair requires that the leaflets come and touch each other so that you can go and clip them. And so when they're this far apart, it's just not possible to get those leaflets close enough for you to apply a clip to. There is a potential role for transcatheter tricuspid valve intervention using a valve replacement prostheses. I think these are still in early days with the approval of these technologies, and we have not seen a lot of use of these. They have technical difficulties. The valves don't tend to stay in valve and have risk of embolization. So this is not really an area that has exploded just yet. They were excluded from the clinical trials. And so by and large, our recommendations have been for surgical intervention for carcinoid heart disease. And if your patient develops degeneration of the valve prosthesis, in those cases, you then have a stable ring. And with a stable circular ring, it's then possible to do a valve-in-valve intervention using an off-label Edward Sapien valve in that position. And so really, percutaneous intervention, I tend to see its role in patients that potentially need re-intervention for this disease process. Dr. Crestanello, do you have anything else to add?
Yeah, I agree. I mean, there's no role for valve repair in these patients, and that's an important concept. This is an ongoing fibrotic process that will continue. So if somebody perform a valve repair, it will make the valve competent for a certain finite amount of time. But then the fibrosis and an inflammatory process will continue, and the insufficiency or stenosis of the valve will develop further. So number one, there's no role for any type of repairs on these valve repairs on these patients, and the surgical replacement is the preferred treatment. We have no experience with any type of transcatheter treatment on these patients. However, as you say before, those who had a bioprosthesis and then develop bioprosthetic valve deterioration can be replaced in a percutaneous fashion. It appears that there's a higher incidence of thrombosis in these patients, and part of the perioperative management is to maintain these patients anticoagulated for longer period of time, and we believe that decreases the chance of thrombosis, and number two, it may prolong the durability of the bioprosthesis, and maintaining the control of the secretion of the serotonin is also important for the durability of the prosthesis long term.
I think that's really extremely important to highlight that increased risk of bioprosthetic valve thrombosis. We thought bioprosthetic valve thrombosis was rare previously, and I remember one of the first few series that we wrote up of bioprosthetic valve thrombosis. And despite the rarity of this condition, a third of that patient in that overall cohort of patients with bioprosthetic valve thrombosis had carcinoid heart disease. So that's something we definitely keep a very close attention to and a very high index of suspicion for. Remember, the valve gradients go up if you thrombose at least two of the valve leaflets. And so sometimes we see anatomically one of the valve leaflets being immobile. And I would generally investigate that further as possible bioprosthetic valve thrombosis. As Dr. Crestanello indicated, it's unusual to have recurrent carcinoid plaque on these bioprostheses. I know in initial experience there was a tendency to place mechanical valves in order to avoid that risk of recurrent plaque, but we really haven't seen a lot of carcinoid plaque on our bioprosthetic valve replacement. The bigger problem is thrombosis, and really that's the cause of valvular degeneration. So having a high index of suspicion, and even though you place a bioprosthetic valve, recognizing the potential need for lifelong anticoagulation for bioprosthetic valve thrombosis. We invite all of you to continue to send in your questions, please. But the next question here, Juan, I'm going to let you have a go at this. You mentioned a small proportion of people get mechanical valves in this disease process. How do you choose which patients we should be putting a mechanical valve in rather than a tissue valve?
Well, that's a very good question. As we say, there's the long-term outcomes between mechanical and tissue valves are not different in these conditions, and the the choice of a mechanical prosthesis is normally left to young patients who otherwise they have the disease process very well controlled, and we presume that they're going to have a long-term survival. In elderly patients, normally we recommend to have a bioprosthesis, but it's basically based on the biological age of the patient, as well as the degree of control of their tumor disease. And obviously, the cardiovascular factors are also important.
I think that's a great point. So by and large, we put in bioprostheses, but if you have a particularly young patient with disease that you think you've cured and things like that, there may be a role in a select group of patients that's going to live many decades to put in a mechanical prosthesis. One of the audience members asked about the place for polymeric prosthetic valves, and I'm not familiar with this one. Do you have?
Well, the polymeric valves are valves that their leaflets are made from polymers of different compositions. There are different valves. None of them are approved in the United States. They are being investigated. The concept behind the polymeric valves is that potentially they can last forever and they don't require anticoagulation. However, like any other artificial valve that came to the market or came to trials with the promise that it's not going to require anticoagulation, they do. And because some of those trials had been suspended because of thrombosis of the leaflets. And none of these valves have been used, as far as I know, in patients with carcinoid heart disease or in the right side of the heart. The trials have been in the aortic position.
Dr. Halfdanarson, can I ask you, perioperative management or procedural management of these patients, avoiding carcinoid syndrome and things like that, what do you routinely do, or what should we be advising our patients before they come to such major procedures?
Yeah, so that's an excellent question. So those patients that we are operating on all have carcinoid syndrome and carcinoid heart disease. So the tumors are producing serotonin and all sorts of other chemicals that we don't measure normally. So we do our best to make sure that the patients going into the procedure have as good control over the functional syndrome and the production of the serotonin as we can, but we can't always completely shut it off. And in fact, most of the time we cannot completely do that. So we use these injections of somatostatin analogs like octreotide or lanreotide. There's a medication called telotristat, also known as Cermello, that reduces the production of serotonin. That may be helpful. But that said, our biggest concern is always heading into the operating room. Is there a risk of the tumor suddenly releasing a lot of these chemicals, causing a lot of problems like drop in the blood pressure, wheezing, and flushing? So that's called the carcinoid crisis. Thankfully, that seems to be fairly uncommon. And if that happens, the surgeons and the anesthesia team have all sorts of ways to deal with it. We can give high doses of octreotide. We can give medications to bring up the blood pressure. So most of the time, we can proceed with the operation and stabilize the patient. So we do our best, as I say, to optimize the management heading into the operation.
Can I ask, in terms of we use long-acting octreotide or long-acting lanreotide, timing of that relative to surgery, is there an optimal time? Should we be giving the injection operating straight after or closer to the next dose? Is there an optimal time, or does it really not matter?
We don't know if it really matters. So these drugs stay in your system for weeks. So I think it makes sense to try to do the injection maybe like a week or two before. Some of them, like the octreotide, takes a little longer to build up in the blood. So the lanreotide takes a little faster. And so I'd say within the last 3 to 4 weeks is probably ideal. I would not want to go much beyond 4 weeks, but if we can get the injection maybe as close to the operating date as we can, that probably would be the best, but hasn't been studied well.
Thank you. And I think one of the important things Dr. Halfdanarson highlighted was the fact that when we send these patients to cardiac surgery or to a procedure in the cath lab, we often dose some octreotide. If it's going to the cath lab, we do a dose of octreotide in the pre-op area. If they're going to cardiac surgery, we're worried about bigger amounts of serotonin, and so we run an infusion going down to the OR and through the post-operative ICU stay as well. And I think one of the difficulties that some centers that don't have experience managing carcinoid heart disease face is not knowing how to manage that carcinoid crisis on table, and that really increases your operative mortality, hence the importance of centers of excellence.
Absolutely, and the whole concept of giving the octreotide or lanreotide before surgery, and whether or not it prevents anything, actually has been recently called into question. But patients need to be on these drugs anyway to control their flushing and the diarrhea. So I think it's very reasonable to continue. And also, if a crisis happens, then in addition to giving the medications, we need to bring the blood pressure up. Giving high doses of these medications is very, very reasonable. But back to your comment there, the best outcomes are likely in centers that deal with this with frequency, do this often. It's just like any other thing. The more often you do it, the better you get.
Absolutely. And
Well,
then,
I was just going to add that it's key to have the long-acting agent within a reasonable time before the surgery. So normally we don't want to get the long-acting agent the day before. We want to have it, several days. I mean, probably within a week of the surgery to have enough time for the levels of the drug, to have a sustained levels of the drugs in the body. And then there's the continuous infusion also is key for the first 48 hours or sometimes longer. And then rescue doses. And anesthesia monitors the patients, and they not only monitors for the occurrence of changes in blood pressure during the surgery, but also for episodes of flashing. So they observe the face of the patient, and obviously we, as a surgeons, you don't see the face, but they inform you if they are flashing. Normally they give rescue doses in the OR and increase the dose of the continuous infusion.
And I know I get a lot of questions on telotristat from our carcinoid heart disease patients. Do you mind, Dr. Halfdanarson, talking about mechanism of action briefly, but more importantly, I know it's licensed for diarrhea, but what evidence is there or not there that it affects the progression of carcinoid heart disease?
Well, absolutely. So telotristat is an interesting drug. So just a little bit of background with the serotonin production. So what happens is that when we eat certain types of foods that are rich in an amino acid called tryptophan, the body will turn that into serotonin. And that happens in like 3 or 4 different steps. And the telotristat actually blocks one of the key steps in that conversion of the tryptophan to serotonin. It's what we sometimes call in chemistry the rate-limiting step. So it's the most important step. So the telotristat really binds to an enzyme or blocks an enzyme there called tryptophan hydroxylase, and by doing that reduces the amount of serotonin in the bloodstream. So this has been shown to reduce the severity and frequency of diarrhea, and is a very helpful adjunct drug in our clinic. It doesn't control the tumor though, and that's important to know. As for the heart valves, that is a very interesting question because it hasn't really been studied yet. So one would think that if you reduce the serotonin concentration, you could actually protect those heart valves from the damaging effects of high serotonin. But it just remains to be properly tested. But that trial is ongoing. So hopefully in the next 1 or 2 or 3 years, we'll have some results.
That's excellent. Hopefully a promising future for these patients.
Very much so. And I think it just goes to show that for patients or conditions like this in general, we need to do appropriately designed clinical trials. So I sometimes tell my patients, there's no way we would be where we are today, knowing what we know today, if it wasn't for patients who participated in clinical trials before that. So that's how we move the field forward. It takes a collaboration of us, the providers, and you, the patients, and your families and caregivers.
Absolutely. And Dr. Crestanello, I know myself and Dr. Halfdanarson send you the highest risk people, and you're always kind enough to operate on them. I remember a patient that I asked you for AVR, MVR, TVR, PVR, plus or minus cabbage, plus or minus appendage exclusion. And when you took my phone call, you didn't say, no way, Alan. You said, yep, I'll see the patient and I'll think about doing it. How do you decide who's an operable candidate and who's not an operable candidate when you see your patients there?
Well, the two things that you have to take in consideration, one is the overall condition of the heart. I mean, the cardiac function and the degree of myocardial dysfunction that is associated with the valvular heart disease is an important consideration. And that determines the extension of the surgery and the ability of the patient to tolerate the surgery from the cardiac standpoint. But also the rest of the patient needs to be considered. What's the overall physiological situation? What's the age of the patient? What's the overall status, functional status of the patient? Does the patient have enough reserve to recover from the surgery? And the evidence of end organ dysfunction, like if they have renal failure, if they have lung disease, other comorbidities that will make the risk of the surgery higher. And particularly in these patients is the extension. Nowadays, we have been paying more and more attention to the extension of the metastatic disease. If the patient have extensive involvement of the liver, and we call extensive more than 75%. If they have extra hepatic metastases, are things that they normally make us pause and reconsider the situation. And also the very important aspect is, irrespectively of the degree of extension of the disease, is whether they have any options for treatment. And sometimes some patients are at the end of everything has been tried. Surgery for the liver disease has been tried. PRRT has been tried. Chemoembolization has been tried. And there's chemotherapy has been tried. And there's no additional treatment that can be provided to those patients to control the tumor. And those are in those situations where we have more reservations in order to proceed with the surgery. I don't know if you want to add something.
No, I think that's a very good point, because we're thinking that with the interventions like valve surgery, we're hoping for years and years and years with good control of the carcinoid heart disease. But if you do not have any remaining good options to control the tumor, then should we really proceed with open heart surgery with the risks associated with that and the recovery time if we can't treat the tumor anymore? So those are always really difficult discussions to have.
Well, we have to remember, number one, that the surgery improves the functional status of these patients. Number two, it prolongs the life, and it changes the way that these patients die. The patients with valvular heart disease or carcinoid heart disease, without treatment of the valvular heart disease, they die from congestive heart failure and they die sooner, while in general patients who have successful surgery, they die from progression of their disease rather than from cardiac causes.
And I would like to tell you about one patient I saw. So I came back to Mayo in Rochester almost 10 years ago, and I had been here maybe for a year or two, and we saw a patient with really severe carcinoid heart disease with lots and lots of symptoms from heart failure. And the oncologist, who's a really, really good oncologist in the community, said, I just don't know if I can help this patient. I have the patient on octreotide, and so she came to us and had valve replacement, had I think 2 valves replaced, and she had a very large liver tumor that was the reason for all of the serotonin production. So the heart surgery went really well. And a few months later, she had the liver surgery and small bowel surgery, where the surgeon removed the small bowel primary, removed the large liver tumor. This was 6 or 7 years ago. Nothing has shown up since. And she is really has excellent quality of life and no evidence of cancer. So occasionally you have those situations where the symptoms are all from the heart, and we can deal with the tumor if we only can take care of the heart first.
Well, that sounds good. Very gratifying story to have cure of disease.
Extremely so. It doesn't, I wish it happened more often than it does, but it certainly can happen, or at least we can set the clock back, sometimes by many, many years.
That's wonderful. It looks like we've got to the end of the list of questions here, and I'm going to ask both you, Dr. Halfdanarson and Dr. Crestanello, do you have any additional comments or words of wisdom for our audience here?
So my comment would be that for someone with any rare cancer, not just neuroendocrine tumor or carcinoid heart disease, it's always appropriate to ask your treating doctor, is there like a center of excellence that does really well with that particular tumor type, in this case carcinoid heart disease and the neuroendocrine tumors, and getting a referral to such a center is a good idea. Also, I will put a plug in for clinical trials and research, is that's really the only way to move forward. So it's always appropriate to ask your doctor, do you have a clinical trial that I might be appropriate for? So those probably would be my two main suggestions.
Thank you very much. And Dr. Crestanello, any additional?
No, I just want to highlight the importance of having a multidisciplinary team with experience in the management of these patients to take these patients through their journey. And the journey is normally is prolonged. We see these patients many times before deciding to do surgery on them. And they are seen by oncology, they're seen by cardiology, they're seen by surgery, they're seen by anesthesia. And the post-operative management and the long-term management after the surgery is also done by the multidisciplinary team. So it's key to have the team managing these patients.
And I would like to just echo that it takes a village to take care of patients with advanced neuroendocrine tumors with complications. So a lot of this is done in what we call tumor boards. We actually meet, we look at the scans, look at the biopsies, and we sort of decide what is the sequence of things happening here, who goes first, who goes next. So it just takes there's a lot of work happening behind the scenes. I'll say that. So it's very important to go to such a place that has those capabilities.
Absolutely. And I know we as a Carcinoid Heart Disease group meet together as well with oncology, cardiac surgery, and cardiology, and we discuss all our challenging patients as well. And it's invaluable to hear the opinions of all our colleagues as we sit and discuss these complex cases.
Absolutely.
So I'd like to thank our audience for their attendance and participation. Thank you very much for the great questions. And I'd like to thank my colleagues, Dr. Halfdanarson and Dr. Crestanello, for being here and presenting on this important topic of carcinoid heart disease. So thank you all very much.
Thank you very much.
Thank you.